Hello, it's my pleasure to speak today about Aicardi-Goutieres syndrome and other calcifying leukoencephalopathies. Before I start, I want to share my disclosures. I received granted in-kind support for our translational research from Eli Lilly, Gilead, Takeda, Illumina, Biogen, Homology, Ionis, Passage Bio, and Orchard Therapeutics. I also serve on the Scientific Advisory Board of the European Leukodystrophy Association and the United Leukodystrophy Foundation, as well as in an unpaid capacity for several of our pharmaceutical partners. Importantly, Eli Lilly provided support for drug safety laboratory monitoring and PK studies for the repurposing strategy I will talk about in this presentation. I will discuss off-label use of baricitinib for the treatment of AGS in this presentation. And then finally, the AGS scale is copyrighted by the Children's Hospital of Philadelphia. Before I start, I want to acknowledge our family foundations who have supported the work in AGS that I will describe, as well as the support from our affected families with AGS. I also want to thank our team, as well in particular Drs. Takunahashi, Drs. Kavatsi, and Dr. Adang for their support in our AGS research program, as well as our federal and non-federal funding agencies. Calcifying leukoencephalopathies are an important diagnostic consideration when you have a patient with an unsolved leukodystrophy. Often, patients are diagnosed with white matter abnormalities based on MRI imaging, which may or may not include calcium-sensitive sequences. And it's important to always keep in the back of your mind the possibility of a calcifying leukoencephalopathy and make sure that your neuroimaging modalities are able to recognize both calcium deposits and hemosiderin. Within the group of disorders that may have calcifications, there are a number of leukodystrophies, as well as non-leukodystrophy genetic disorders, and finally, acquired disorders or conditions. The most frequent disorders that have calcium deposits within the leukodystrophy families are Aicardi-Goutieres syndrome, CRMCC, and LCC, which were previously thought to be the same disorder, with CRMCC also known as Coates plus. Now, those two disorders are known to be non-allelic, as well as a completely different disorder, RNase T2 deficient leukoencephalopathy and Krabbe disease. Less frequently, one can see calcifications in Alexander disease, oculodental digital dysplasia, and XALD. Within the non-classic leukodystrophy family, there are a number of disorders that can also cause calcifications with underlying genetic causes. Probably the most frequent of those are the mitochondrial leukoencephalopathies, as well as the group of disorders with a number of disturbances of the vascular wall, including cadicel, carousel, and collagen for A1 defect, which can also result in hemosiderin deposits. Within the acquired disorders, the most frequent one to think about is congenital cytomegalovirus infection, which we'll speak more about in a minute. To speak briefly about the radiologic manifestations of our disorders with calcification deposits, Aicardi-Goutieres syndrome is going to be the most frequently seen. Importantly, in Aicardi-Goutieres syndrome, you may have an early picture with temporal lobe abnormalities that are reminiscent of congenital infection, with temporal and frontal predominance, sometimes cyst-like formation, especially in the temporal lobes, and occasionally multifocal white matter abnormality and basal ganglia calcifications. Also within the genetic disorders, you have leukoencephalopathy calcifications and cysts. This one bears specific mention because those patients may be missed on standard diagnostic imaging because the genetic cause of it is in the non-coding region, and therefore may be missed on testing such as exome approaches. This disorder results in significant basal ganglia disruption and a progressive leukoencephalopathy. It's important also to be prepared to recognize the radiologic manifestations of congenital CMV. In congenital CMV, you can have temporal lobe and horn involvement, such that there are structural abnormalities and differences within both the temporal lobe and horn, which on a sagittal view can result in sort of an outpouching appearance of the temporal tip of the temporal horn This can be helpful in recognizing congenital CMV and is a useful diagnostic marker. For more information on that, please see a 1999 publication from Dr. Vanderver in radiology. In addition, you can have multifocal white matter abnormalities, dysgenesis of the cortical layer and the cerebellum, as well as delayed myelination or multifocal white matter abnormalities. Congenital CMV is a not infrequent diagnosis, and honestly, if you have a patient with abnormal white matter and calcification, statistically, the most likely diagnosis is congenital CMV. And so it's important to be prepared to recognize this disorder has significant reproductive implications for the family, as congenital CMV is obviously much less likely to recur than a primary genetic recessive disorder. And I would consider it early and often within your diagnostic strategies. Patients may present to clinic too late for urine and blood PCR, but think about retrieving the newborn blood spots for CMV PCR to make a definitive diagnosis, as this can be very helpful for families. However, at this point, I'd like to focus the remainder of the talk on Aicardi Goutieres syndrome, as it is within the genetic disorders causing calcifying leukoencephalopathies, one of the most frequent causes. Aicardi Goutieres syndrome is a heritable disorder of interferon production. It's a multi-system disorder because interferon is toxic to multiple organs, not only the brain, but also particularly the liver, the hematologic system, and the skin, as well as numerous other organs. It's important to note that not all features are obligate and that some patients have very mild neurologic disease and more significant systemic disease. And it's thought that there's a mixed mechanism of both interferon injury versus secondary vasculopathy, and certainly the injury in the brain also represents a calcifying microangiopathy. And these patients require significant multidisciplinary anticipatory care to avoid serious morbidity and mortality. Suggestive features that should make you think as a neurologist about Aicardi Goutieres syndrome are a combination of either a subacute or a chronic encephalopathy, along with hematologic or hepatic abnormalities on basic laboratory testing and abnormal skin findings. There is no available alpha interferon level that can be measured clinically, but useful laboratory markers include CSF pleocytosis, neopterin, and tetrabiopterin testing, which is available typically as part of a neurochemistry panel. And then there are some research labs that are offering blood interferon signature based on the expression of interferon signaling genes. From a diagnostic perspective, it's important to check all 7 involved genes and to consider that not all may be detectable on exome, as some patients will have deletions, in particular in SAMHD1. And if you make a diagnosis, it's important to screen carefully across all potentially affected organs. AGS is known at this time by 7 different genes. These genes represent a pathway that is typically engaged in viral sensing and response, and ultimately the production of interferon, which explains why there's so much clinical overlap between AGS in early onset cases as well as congenital CMV. Overall, it's a disorder with severe clinical manifestations. And if you look at the patients overall across all genotypes and look at a heat map of their acquisition of developmental milestones, with warmer colors being a greater percentage of patients acquiring a milestone and cooler colors all the way to purple, including fewer patients acquiring milestones, you can see that the most consistently achieved milestone is smiling, which is a very severe disorder indeed. However, it's important to note that there's some degree of genotype-phenotype correlation, with TREX1 patients being more likely to be more severely affected, and ADAR, IFIH1, and SAMHD1 patients being much more likely to have a mild course. It's also important to note that there is a temporality of this disease, with most patients presenting with significant worsening in the first 6 to 12 months of the disease, and later a stabilization around a more static course that's unfortunately often very severe. There's a subset of patients who don't present in the originally described fashion of a early infantile subacute encephalopathy, but who instead present after a year of age with an acute neurologic decompensation after a period of developmental delay or primary systemic symptoms such as skin findings or other inflammatory measures. And in some cases, those patients can present very late indeed, in particular if they present with acute striatal necrosis, which is particularly seen in ADAR1, with neuropathy or myopathy, or with a primary CNS large vessel vasculitis, such as seen in SAMHT1, which is known to be associated with moyamoya. Overall, this results in a heterogeneous clinical presentation with a majority of patients currently known still to present with a severe presentation with microcephaly and profound developmental delay, like the little boy on the right, but then with a significant subset of patients presenting with preserved cognitive features but profound motor dysfunction, or with a picture much more consistent with spastic diplegia, like the little boy all the way on the left here, or sometimes even very preserved neurologic function. The little boy in the stroller ultimately learned to walk and went to school in a fairly age-appropriate fashion. This broad disease presentation likely explains why this diagnosis is currently, we think, under represented. And when you look at the results of agnostic genetic testing, such as with whole exome sequencing, you recognize that AGS is actually a not infrequent cause of leukoencephalopathy. So the pie chart on the left, right, represents patients who were diagnosed based on exome. The pie chart on the right represents patients who were based on exome and targeted testing, all having identified abnormalities in leukodystrophy-associated genes. And you can see that when a purely agnostic approach is used, AGS is number one and represents a significant proportion of overall leukodystrophy diagnoses, versus when a more targeted approach is also incorporated along with whole exome sequencing. Disorders such as adrenal leukodystrophy caused by ABCD1 mutations or metachromatic leukodystrophies caused by ARSA mutations are much better represented, but still, even in this case, AGS is a significant proportion of the overall population. So thus, I think if you're a child neurologist and you have not previously seen a patient with AGS, it is very possible that you're actually missing these patients. It's also, I think, of interest that interferon activation precedes overt disease, sometimes by a significant amount. In a study that was recently published, we looked at the newborn blood spots of patients who ultimately were diagnosed with AGS, and we were able to detect an interferon signature in a majority of those blood spots, sometimes up to 3 years before the actual diagnosis of the disease with presentation of neurologic manifestations. I want to now talk briefly about open label use of Janus kinase inhibitors in Aicardi syndrome. At this time, there are no currently established therapies in AGS. When the causative genes were identified and it was understood that the genes were involved in immune stimulatory pathways, a number of different immune modulating therapies were tried without success in this disorder. There have also been brief reports of some of these therapies in the literature that do not have significant clinical outcomes. Because a number of the genes are also responsible for the accumulation of nucleic acids, and there was suggestion that endogenous effector elements accumulated and were immunostimulatory, there was also a therapeutic trial with reverse transcriptase agents also used for HIV. This study was not powered for clinical outcomes, and it remains to be seen whether or not this will have a clinical benefit. Thinking about treatment options in this disorder, however, given the multiple different potential mechanisms and the multiple different genes, it's attractive to look for somewhat downstream approaches of blocking the impact of interferon on target cells. And one way to do that is through inhibition of Janus kinase phosphorylation. When interferon engages with the interferon receptor, this induces Janus kinase phosphorylation, which triggers a series of intracellular events that ultimately result in interferon gene signaling. There is a class of medications called Janus kinase inhibitors that are designed to block Janus kinase phosphorylation, and they have been used and approved for disorders such as psoriasis and rheumatoid arthritis. So several years ago, we opened a compassionate use protocol with the help of Eli Lilly on an expanded access basis. And as part of that study, we enrolled 35 patients with genotype-confirmed AGS. Those patients included patients who had systemic signs and symptoms of inflammation that we felt we could improve with Janus kinase inhibitory use. Importantly, those patients might have had years of disease duration with a mean age at treatment of 5.9 years, despite a mean age of onset of 0.8 years. The patients were predominantly male for reasons that are not well understood. Overall in AGS, there are more male patients than female patients, and we followed those patients for at least a year of visits on a study drug, although some patients for much longer, up to 4 years. During the study, we followed daily clinical diaries of symptoms that included features of irritability and poor sleep, as well as systemic features such as fever, skin findings, and also seizures. And overall, there was an improvement in diary scores, although there was still individuation. Similarly, we saw an improvement in interferon signaling gene scores that are calculated by looking at interferon signaling genes by nanostring, which is a type of multiplexed RT-PCR, and looking at the expression of those genes as a z-score compared to normal population. These were collected at baseline and on study, and while overall they improve on study, I would like you to note that there's still significant fluctuations, that when, for example, patients had intercurrent infections or other triggers, we could see significant elevations of the interferon score, but overall, it's as if the interferon signaling thermostat was reset with patients. There were visible skin improvements during drug treatment, and you can see here that sometimes even mild skin abnormalities that had been present throughout the child's life improved, but also sometimes such much more significant skin involvement such as paniculitis or digital involvement resulting occasionally in amputations and recurrent osteomyelitis and cellulitis improved. The patients also improved by a measure that was developed to test AGS patients, the AGS scale, which shows a series of developmental milestones that are each scored, such as learning to sit, learning to develop a pincer grasp, or different types of mobility, including floor mobility or standing mobility. And each point on the scale represents a discrete milestone of improvement. And you can see that before treatment, patients were either static or had predominantly declines in the AGS scale, but that a proportion of these patients had improvement in the year after such that before treatment, a number of patients lost milestones and a smaller percentage gained a small amount of milestones, 1 to 2, and that in the year after treatment, only one patient actually who had drug discontinuation briefly due to concern for an infection had a decline in milestones, and a proportion of patients actually had improvement even of significant numbers of milestones. This improvement in milestones as measured by the AGS scale was also proportional to some degree to whether or not patients reached a target drug dose. There were some patients who were unable to reach a target drug dose because of side effects. Safety monitoring was a key consideration during this compassionate use trial. Janus kinase inhibitors are associated with a number of different laboratory abnormalities, most importantly, cytopenias. For baricitinib, rather than having thrombocytopenia, this drug is usually associated with thrombocytosis, and that was the most consistent abnormality we saw, although there were also problems with anemia and neutropenia during the study, none of which which overall did not reach statistical significance throughout the entire cohort. There was some suggestion of improvement of liver function testing. While on study medication, however, one individual died secondary to pulmonary hypertension that was felt to be related to AGS and not related to the medication. There was another patient who died of multi-organ failure after prolonged unexplained anemia and thrombocytopenia. This patient had been treated with high-dose steroids in addition to baricitinib since before starting baricitinib, and had really several years worth of high-dose steroids. On autopsy, fungal pneumonia was found, and it's unclear at this point if this was related to his high-dose steroids or to a combination of the steroids alongside baricitinib. And there's a third patient who had unexplained sudden cardiorespiratory arrest, and an autopsy is pending for that patient. During a second, still ongoing IND open label study, there were no patient deaths, but there was one patient who discontinued study medication due to pancytopenia, and there was a higher frequency than in the original compassionate use study of clinically non-significant low neutrophil counts. And so overall, we recommend that patients who are undergoing baricitinib treatment with, in the context of AGS, have careful monitoring of cytopenias, as well as monitoring of other laboratory findings, including lipids and CPK, as well as standard biochemical testing. And we also recommend that patients be carefully monitored for infectious risk with careful pre-drug initiation screening for a number of different infectious parameters. And finally, it's important to note that these patients cannot receive live vaccines while on baricitinib, that this requires careful counseling prior to initiation of baricitinib. So in conclusion, I think the most important thing from our findings is that it looks like Aicardi Goutieres syndrome may actually be at least partially treatable entity with baricitinib as a potential disease-modifying therapy, and that therefore it's important to identify this disorder and diagnose it early so that appropriate management can be begun. Also, as part of appropriate management, it should be considered that anticipatory guidance for this multisystem disorder is very important. And so that if you diagnose one of these patients, you need to be thoughtful about the fact that they will require multidisciplinary management and that they might be appropriate for referral to a complex care pediatrics program, because they will need coordination of evaluations such as yearly eye examinations for glaucoma testing, yearly MRI, MRA if they have SAM-HD1, yearly laboratory testing, including a CBC, liver function testing, urine analysis, thyroid testing, and monitoring for diabetes and diabetes insipidus. A yearly echocardiogram and EKG for the potential cardiac abnormalities that can be seen, including review of that echocardiogram for the manifestations of pulmonary hypertension. And then that patient will also require regular neurologic exam for evidence of myopathy, neuropathy, and joint involvement, as well as daily skin review by parents and avoidance of cold and pressure. Finally, these patients may have dental root resorption, presumably due to gingival inflammation, and require very careful dentistry management. So in conclusion, Aicardi Goutieres syndrome is a highly variable disease affecting lots of organs in different ways in different persons. Baricitinib should be considered as a disease-modifying therapy, and most importantly offers proof of principle that this is a treatable disorder, but treatment with baricitinib needs to be very carefully monitored and likely requires collaboration with an immunologist or rheumatologist. And in addition to targeted therapies, disease monitoring is very important to the overall health of your patient with AGS. Thank you very much for your attention. And I hope that this has been helpful in recognizing this important disorder.
Happy to take any questions.
So we do have a couple questions. It's a multi-part question, so allow me to unpack it. With newborn screening picking up abnormalities, what are your thoughts on the following? Imaging at baseline in an otherwise normal infant, ideal age to image, what sequences with or without GAD, and lastly, is there a short list of leukodystrophies with diagnosis where imaging is asymptomatic? Imaging an asymptomatic infant is necessary.
So I started answering that question already in the chat earlier in the morning. I think it's very important that we don't know at this point, based on newborn screening, how we're going to best follow these infants, and there are ongoing efforts by others led by teams in other groups, for example in ALD, to try to understand what the best frequency and type of imaging that is necessary for follow-up of newborn screening results. And I think it's impossible to answer that question at this time until we have a better sense of what those natural history studies are going to demonstrate. And I think it's also important that the answer to that question be disease specific, because there are disorders where MRI imaging drives treatment response and treatment intervention, and there are disorders where it might play a much less significant role. And so I don't think it's possible to answer that question with the knowledge we have this time and without thinking about these diseases discretely as individual disorders.
Okay. If there are other questions from this lecture, we'd leave it open for a little bit for anyone to post their questions in the Q&A. Looks like we have one. So the question is, why do patients with AGS and SAMHD1 mutation need MRI and MRA yearly?
Thank you. So patients with SAMHD1 mutations are unique amongst the patients with Aicardi Goutieres syndrome in having a higher frequency of large vessel vasculitis. And so we recommend yearly MRI, MRA in order to assess whether or not the patients are developing large vessel vasculitis complications, which can develop after even years of disease progression, that appropriate management and monitoring of complications like moya can be performed on those individuals. That risk for large vessel vasculitis, while not completely nil for other genotypes, because I have seen large vessel vasculitis, for example, in very severe patients with TREX1 mutations, is so much less likely as to not justify routine screening, and more likely to be associated with patients who are having very severe disease manifestations and early on in life when you might be getting radiologic imaging anyways.